problem, Patrick. Thank you for having me. So, as Patrick says, Ivers, I'm from the discipline of public health at the School of Medicine in Trinity College Dublin. And I suppose I head up the neurobiological lab there that looks at, I suppose, what makes somebody vulnerable, either from a neurobiological and social perspective, what makes someone vulnerable to addiction, and also then what makes people susceptible to recovery. I'm the Dean of Civic Engagement for Societal Impact, also at Trinity College. And I suppose in terms of public health is effectively community health. And a couple of years ago, I suppose I started to advocate for the reorientation of our systems of care towards that of a recovery-based model. And it was during that time that I reached out to Professor Kelly, who, you know, has always been a real hero of mine. He's, you know, one of the 5 biggest names in addiction recovery. He holds the Esther Spillane Chair in Addiction Medicine at Harvard Medical School. And just for the academics amongst us, that's the highest accolade you can have as an academic. He also heads up the Recovery Research Institute, producing lots of evidence and lots of accessible science, and he makes all of that available to communities free. So if you haven't registered with the Recovery Research Institute, I would urge you or drive you towards that. There's buckets of free evidence-based studies and resources for people who are interested in the science of addiction and recovery. But I want to say one thing in terms of John as a person. He's incredibly generous and kind, because a couple of years ago, as I say, when I reached out to himself and other good colleagues, Keith Humphreys, David Best, Ed Day and Emily Hennessy, they were really quick to come to Ireland and share that science and really engage our policymakers. And it was during that time that there was a lot of convincing and a lot of political will put into trying to drive our services towards that. And I have to say, without their generosity, that wouldn't have happened. So I'm forever grateful to John for that, and then other opportunities to collaborate with him and his group. So without further ado, I will hand over to John.
Can you see my slides?
Yes.
Fantastic. Can you hear me okay?
Yep.
Fantastic. Jo-Hanna, thank you so much. Great to see you, number one, and thanks for the very kind and very warm introduction, and Patrick as well. It's been such a pleasure getting to know Patrick just in the last few weeks as we were planning this engagement, this talk, and I'm honored to be here with you all. Congratulations on the person celebrating, I forget how many years now, but congratulations on your sober anniversary today. Yeah, just honored to be with you and to have the invitation and opportunity to present some of the data that we have gathered and the research findings we've learned about, some of which I've conducted myself, but that's really been conducted in the last 30 years, which is really shining a new light of evidence on 12-step treatment and mutual help groups, 12-step based mutual help groups like Alcoholics Anonymous in particular, but other groups as well, showing their particular clinical and public health benefit as well as cost effectiveness, and that's and mechanisms of behavior change, how they work as well. And this is something that's we've learned also a lot about in the last 20 to 30 years, as there's been a lot of focus in this area. So what I'm going to do today in the next hour is give you an overview of that kind of rationale and background of this focus area in 12-step treatment and AA research and other 12-step research, give you a little bit of background and rationale, and then I'm going to go into a lot of the findings which are supporting both 12-step treatment and the efficacy, effectiveness, and cost effectiveness of groups like Alcoholics Anonymous. Just a little bit of terminology orientation, because there's a lot of confusing, perhaps, terminology has specific meaning in certain contexts, and can be bandied around, without much attention to that. But I'm just going to cue you in here to some of these different ways of thinking about 12-step, quote unquote, 12-step treatments and essentially entities that are all designed to do the same thing, and that is to get people into remission, into recovery from these deadly, debilitating disorders. The first one is 12-step facilitation. You can see at the top, that's a fairly new term. That is a clinical treatment term. It was coined in the 1990s to really describe essentially clinical outpatient manualized treatments, which are designed and tested to link patients to AA, essentially. And those treatments were called 12-step facilitation. So the word facilitation is meant, of course, in a significant way, in the sense that the clinician is responsible for describing, talking about, educating patients about 12-step meetings, as well as prescribing attendance and monitoring attendance, and helping the patient become engaged during treatment so that can support the person after treatment is finished. 12-step treatment is another term that usually refers to inpatient treatment. When someone says 12-step treatment, they're usually talking about an inpatient experience, which is based around the 12-step principles and practices of Alcoholics Anonymous. The Minnesota model is another variant, a broader model that came out of Minnesota, obviously the United States, in the 1940s, and has grown around the world since then. Is essentially a multidisciplinary model, which the heart of which is a 12-step philosophy. The idea is to stabilize people in an inpatient residential setting, get them to understand the concepts, 12-step concepts, in the hope that they will continue to utilize those concepts and practices to their benefit, to prevent relapse in the ensuing years of their life following treatment. And then 12-step groups or mutual help organizations, these are things that, of course, all of these treatments are designed to link to. So things like Alcoholics Anonymous, Narcotics Anonymous, and the myriad other 12-step organizations, which are designed to do the same thing, which is help people achieve recovery, long-term stable remission. So that's just a little bit of overview in terms of the terminology. I'll be talking mostly about mutual help groups like AA, as well as 12-step facilitation and 12-step treatments, which are residential. Now, why talk about this? Why focus on this area of treatment and recovery support infrastructure? Well, of course, we're here. You're here because you know too well just the impact that drugs like alcohol or other drugs can have on your people's lives, on your own life, as well as the lives of people right across the world. We know that about 3.3 million people die every year from alcohol. That's 10 times more than all illicit drugs combined. It's the top risk factor for premature death among men of working age worldwide. And it contributes a massive burden of disease and disability across the world. It's one of the most preventable causes of premature death and disability worldwide, particularly in middle and high-income countries. Now, when you think about that burden of disease and disability, premature mortality attributable to a disorder like alcohol use disorder, obviously we need, and societies have constructed infrastructure, clinical public health infrastructure, to help address it as part of the solution. Now, part of that infrastructure is Alcoholics Anonymous. That's not a formal part of the clinical public health infrastructure, but it is de facto a part, just because AA has grown over the past 90 years, coming up for a 90-year birthday on June 10th, since its origin. And it's grown from 2 people to more than 2 million people. And that has been sustained for many decades. So it is the world's largest recovery support service globally. About 2 million members, that's very conservatively estimated across roughly 120,000 groups. The other thing about the importance and significance of understanding the utility of groups like AA and treatments that link patients to it is that we know that these disorders are susceptible to recurrence, to reinstatement, to relapse in the early months and early years of stability as people try to stabilize and find a lifestyle that's conducive and supportive to long-term change. And this graphic highlights this long-term clinical course that we see in addicted patients. These are people with alcohol or other drug disorders. But what's highlighted here, if you look in the middle, after people start to seek help for an alcohol or other drug problem, it takes about 8 years on average to get that first year of sustained remission. So it's quite a long time to get 1 year of sobriety, if you will. And about 4 to 5 treatment or mutual help engagement episodes during that time. Now, what's also noteworthy, if you look on the right-hand side of this graphic, is after people achieve that first year of sobriety, that first year of full sustained remission, it can take roughly about another 5 years before the risk of meeting criteria in the following year for an alcohol or drug disorder drops below 15%. Why is 15% significant? Because that's the annual risk in the general population. So to be no more likely than anybody else in the general population of meeting criteria for one of these disorders in the following year, if you've already had it, takes about 5 years of continuous abstinence, continuous sobriety, continuous remission. So that is a significant milestone. Signifies and indicates and highlights is the fact that during that first year and first 5 years of recovery, people remain susceptible at higher elevated risk for reinstatement of this disorder relative to the general population. The other advantage from a public health standpoint is that these resources are highly adaptable and adoptable in communities around the world. They are available, accessible, flexible, enduring, and low to no cost, of course, operating through nothing more than voluntary contributions. And the 12 traditions on which they're based, of course, has again been a game changer in terms of how an organization that refuses outside monetary contributions has able to exist and persist for nearly 90 years and grown and be influential. Now, from a clinical practice standpoint, clinical medicine and clinical, broadly speaking, standpoint, you can see why, if you didn't know the evidence for these resources, how clinicians might feel very skeptical about their clinical and public health utility. And this is not a new thing. Here's a quote right here from a administrator of a hospital in Manhattan. This was 1937, but it was published here in the 12 Steps and 12 Traditions book of Alcoholics Anonymous in 1947. But in 1937, when this administrator was observing this fledgling group of alcoholics who, this was before AA, but it was the precursor to AA. When he saw what was happening, this is what he said. He said, when my head doctor, Dr. Silkworth, began to tell me of the idea of helping drunks by spirituality, I thought it was crackpot stuff, but I've changed my mind. One day, this bunch of ex-drunks of yours is going to fill Madison Square Garden. Well, he had the right idea, of course, but it's grown exponentially, filling Madison Square Garden by 500,000 times over, because the Madison Square Garden's about a capacity of about 18,000 people. But he was on the right track. What he observed, despite his initial skepticism, was something that changed his mind. And that was that this thing was working to help patients in his hospital that weren't able to stay sober before. So they were onto something, and he saw it. Now, if you think today in the modern age of, we have injectable once-a-month medications for alcohol use disorder, as well as opioid use disorder. We have all kinds of brain neuroimaging and genome-wide association studies of genomics and genetics. This seems foreign and out of step and archaic compared to our modern scientific approaches to psychiatry and to addiction. If you think about, these are deadly disorders that I've mentioned. They produce a lot of disease and disability as well. So for clinicians to think about referring patients to church basements where they're going to work on a set of religiously worded steps, quote unquote steps, based around the idea of God and a higher power, that seems very foreign to modern science and medical technology. Perhaps the only steps these individuals should be taking from that standpoint would be the ones leading them up and out of the church basement and into the sunlight of real clinical science. But again, this guy saw something different, and what I'm going to tell you today, I think, is compelling in that regard. So what happened in the last 30 years was a big turnaround in terms of focus and research in this area. The National Institute of Medicine in the United States published this volume on the left called Broadening the Base of Treatment for Alcohol Problems. And in it, it asked for more research on Alcoholics Anonymous in particular, as well as the mechanisms of behavior change through which it worked. The reason is because there was a lot of confusion around the potential efficacy and effectiveness of AA and treatments that were linking patients to it. And this was a very wide, broad phenomenon at the time, because most treatment in the US was based on a 12-step model, but we didn't really have much clinical confirmation of the efficacy of that model. So the Institute of Medicine called for more research, and this was followed up by a lot of funding in the United States from the National Institutes of Health, as well as the Department of Veterans Affairs, two big national organizations which fund a lot of research in medicine as well as psychiatry and addiction. Following that call for more research, Bill Miller here, you can see in the top left, and Barbara McCready, both very influential figures, of course, in the addiction field historically, convened a meeting in New Mexico, to which they invited all the top alcohol researchers at the time. This was early 1990s. And they sought to publish a volume, which is seen here on the right, really documenting up to that time all the research that was published on Alcoholics Anonymous and 12-step treatment, as well as what was known about the mechanisms of behavior change. Now, the reason why they did that was because they wanted to create an agenda, research agenda, that would set the course for what has turned out to be the next 30 years of focus that I'm going to tell you about in terms of what we've learned about Alcoholics Anonymous and treatments that link patients to it. Now, the way the research has gone since that time is that it has improved tremendously in terms of its scientific rigor. So that call from the Institute of Medicine, which is a very, of course, well-respected body here in the United States and around the world as having authority and credibility, meant that people took that call very seriously. And the NIH, the National Institutes of Health, funded dozens of studies that I'm going to tell you about, as well as the Department of Veterans Affairs here, which is the largest healthcare system in the world, funded research to look at this. What I'm showing you here is a graphic depiction of the different types of treatments. These are 12-step facilitation treatments. And as I mentioned earlier, those are clinical treatments designed to link patients to AA. And this just gives you an array of the different types of studies that have been conducted to test the efficacy and effectiveness of a linkage to AA for people with severe alcohol use disorder or alcohol addiction to AA compared to other kinds of treatments. So on the top left, these kinds of things have been tested in different ways. And the top left shows one of the ways in which this type of treatment has been tested. And this is as a standalone treatment. So the idea here is that you just have a pure focus on 12-step groups, how to get patients, tell patients what the basic tenets of those groups are, the philosophy, the practices, prescribe attendance. So I'd like you to go to 3 meetings this week, and keep a log of your experience. And when we meet next week, come back and we'll discuss what your experience has been. And that's been one of the modes, nothing but a focus. And that's been compared to other kinds of treatments like cognitive behavioral therapy for addiction, for example. In the middle of the top, you can see a kind of a hybrid version on the right, that black and orange bar representing a hybrid version where people are getting some 12-step facilitation. They're getting an understanding of what a sponsor is, a home group, the steps, et cetera, what to do in prescribing attendance, but they're also getting other kinds of things like CBT type things. And that's being compared to just pure CBT or other kinds of interventions by itself. In the top right is a kind of more of an intensive outpatient type setting where you have a number of groups operating across several weeks where patients attend. But one of those groups or one of those components of the intervention that is delivered across those weeks is a 12-step specific intervention designed to help patients become involved and engaged in groups like AA. The last one on the bottom left is what I call a modular appendage. So it's basically you do whatever you normally do in treatment, and then at the end of your treatment, you perform some kind of linkage for your patients so that you can get them securely engaged into AA or another 12-step group, again, to support their recovery post-discharge. So that's the way these have been tested. The other thing that's happened, as I mentioned, is understanding the mechanisms. And this really highlights in an overly complicated way, because I'm feeling a little insecure and I have to pretend I'm a scientist here. So I draw lots of boxes and arrows to make it look like I know science, which I do actually. But anyway, it's actually not that complicated. But the point here is that there has been a lot of sophisticated mechanisms research to understand, okay, well, if treatments like 12-step facilitation actually produce as good or better outcomes, how does it do that? How does it confer that benefit, not just over the early months, but over the years, the early years of recovery, as I'll show you. So I'll just give you a few examples of these different types of models that have been tested and their results, just to highlight before I go into more of a broader summary of the findings on this in this area that's been accumulated in the last 30 years. So the first one on the top left, this is where a treatment is compared. This is a 12-step treatment that's compared. It's a pure 12-step treatment compared to other kinds of treatment, pure treatments like cognitive behavioral therapy or motivational enhancement therapy. And then patients are followed up after discharge. The most famous and earliest big randomized example of this kind of treatment was conducted in a study called Project Match. Project Match was the largest trial of psychotherapy ever undertaken. It cost almost $30 million, and it was conducted across the United States. And there was a very large sample of 1,700 patients of different levels of severity. And they compared 3 different types of treatment to which patients with severe alcohol use disorder or alcohol addiction were randomized. They were randomized to one condition was a cognitive behavioral therapy condition. Another one was a state-of-the-art motivational enhancement therapy. This was focusing on mobilizing intrinsic motivation to facilitate recovery. And the third one was this 12-step facilitation, which was a brand new type of treatment manual that they devised specifically for this study. The idea of which, of course, as I mentioned, was to link patients to AA. They didn't have high hopes initially. I wasn't part of this study, but I know several of the major people who are involved in this study. They thought that 12-step facilitation would make a nice control condition relative to the active psychotherapy conditions in CBT and MET. But what actually turned out was surprising, both for the researchers as well as, I think, for the broader addiction research and treatment community. If you look at these graphs, you can see the highest bar there is the 12-step facilitation condition. So the 12-step facilitation patients who were referred to AA, when they compared those patients to those who were randomized to receive cognitive behavioral therapy or motivational enhancement therapy, they found that the the 12-step facilitation groups did much better in terms of producing higher rates of continuous abstinence and remission. And you can see here both in the first year on the left after treatment and then across the first 3 years after treatment, they found a significant substantial advantage for patients randomly assigned to receive this linkage to AA. Now, these are probably conservative estimates because many patients also who were not prescribed to go, they weren't recommended to go to AA, did actually go. So it's probably a conservative estimate of 12-step facilitation. But what's striking here, when you look at the relative advantage compared to receiving 12 sessions of CBT or the MET condition, was that 60 to 71% more patients were in remission and completely abstinent in 12-step facilitation compared to the cognitive behavioral and MET groups comparatively. Another example is the, and let me just back up for a second here, but I guess it's worth, when you think about how deadly these diseases are that 3.3 million people, if you compare this to something like colorectal cancer, which kills about 1 million people, if I told you that, there's 3 treatments available, they all equally shrink the tumor down to by about 90%, but one of them actually results in complete sustained remission at a rate 60 to 70% higher than the other 2, and it's actually more cost effective. It doesn't have any higher profile of side effects either. So if you think about that from a cancer intervention standpoint, I think it makes good sense why people would choose the one that can actually not only reduce the tumor size, but is also cheaper, and it also produces higher rates of complete sustained remission. And I think that's what is shown here. If we compare that, translate that to this finding in alcohol addiction. Another example is this hybrid version where patients are given some kind of hybrid version of 12-step facilitation combined with something like cognitive behavioral therapy. This was a nice study conducted by, a randomized study conducted by Kimberly Wurlitzer at the Research Institute on Addictions in upstate New York. And what she did was she randomized, these were alcohol use disorder patients on the severe end of the spectrum to 3 different types of intervention. One was a directive approach, where it was a 12-step directive approach where she prescribed attendance. So they talked about AA, what AA is and does, and then said, I'd like you to go to meetings and come back and talk about it next week. So it was more prescriptive. The next condition was a 12-step facilitation condition also. It was a 12-step hybrid condition. But in this condition, it used a motivational enhancement approach to 12-step facilitation. And what I mean by that is that it left it up to the patient in a true client-centered way. It says, well, what do you think about going to AA? Do you think it might be good for you? So it wasn't prescriptive, but rather left it up to the client to decide, to the patient to decide. And both of these 12-step type flavors of 12-step facilitation were compared to a third condition, which was more standard cognitive behavioral therapy with no special emphasis on AA. And what they found was that the only one that made a difference was the prescriptive directive 12-step facilitation. So if you left it up to the patient but didn't prescribe it, didn't say, I'd like you to go, you said, what do you think about going? Those patients did no better than just stranded CBT. The group that did the best by 10 to 20% was the group where the clinicians prescribed it. So I'd like you to go this week, to go to a few meetings, keep a track, and come back and talk about it next week. This was a similar study that was done by Mark Lett at University of Connecticut. And again, randomizing patients to receive either a clinical linkage to AA and encouragement to attend AA, or other kinds of social support for recovery and abstinence. And what Mark found in this study, you can see here on the top right, is just the magnitude of the benefit, about 10 to 20% higher remission rates at 2 years relative to patients who did not get that recommendation, just got standard cognitive behavioral therapy. Another example I mentioned is this intensive outpatient module kind of 12-step facilitation. And Leanne Cascudas in California conducted a nice study. This is, I think, an important study in particular because it's the only group study. So it was a group format. It was intended, therefore, to be more ecologically valid because most addiction treatment, as you may know, is delivered in group formats, in whether that's outpatient or inpatient models. And what she did was develop a 96 weekly 90-minute sessions, which really kind of helped patients understand, you know, what is AA and 12-step groups? What do they do? What's a sponsor? What's a home group? What are the steps? What do the slogans mean, et cetera? And so she educated and talked and discussed, and then she followed patients up. And she compared this to treatment as usual. So this was a more well-articulated 12-step facilitation treatment compared to treatment as usual, which was also had 12-step elements in it, but wasn't as well articulated. And what she found, again, similar to the other studies, was a 10 to 20% increase in remission across the year follow-up compared to treatment as usual. So again, focused, well-articulated linkage, discussion and linkage can result in better outcomes in intensive outpatient treatments. Another study, type of study, as I mentioned, was this modular add-on, kind of a linkage component that's added on to the end of treatment, or just a linkage treatment by itself. This is kind of a compelling study. It was an old study published in 1981. And what was particularly compelling in this study was just the magnitude of the effect. It was a small study where they randomized patients to receive either a what they call a standard referral to 12-step groups. So this would be getting a meeting list and encouraged to attend. And they compared that to the same thing, which is getting a meeting list and encouragement to attend, but also speaking to an active member and arranging to go to a meeting in a counselor's office. So they had this kind of live call with a prospective partner, linkage partner, that they would then agree to meet and get to a meeting. And then they followed up in the first month just to see how many in each group, the standard referral versus the enhanced linkage referral, actually made it to their first meeting. Well, interestingly, I won't do it now, but I always pitch this question to the audience, which is, you know, how many people do you think went in the standard referral condition that were referred to go? And how many people made it in the enhanced linkage condition when they were talking to an active member and agreeing to go? Well, the difference couldn't be starker. Nobody went. Nobody, 0% went in the standard referral. These were people who'd never been before, by the way. That's an important fact. They'd never been, so these were novices. 0% went in the standard referral when they got the meeting list encouragement to attend. Everybody went when they got on the phone and actually talked to someone and arranged to go to a meeting. Not only that, but look what happened in that 4 weeks. They went to, on average, 2.3 meetings in that first 4 weeks relative to 0 meetings. So think about that. Just that simple structure of having a warm, what we call now a warm handoff. That is talking to a prospective, a current member of AA or NA, and then linking, agreeing to meet and go to a meeting, results in getting across that threshold into that space and, you know, getting to 2 to 3 meetings in that first month on average. This was followed up, that original study back in 1980 was followed up by Christine Timko's study. She did a couple of these studies, again, showing very similar results in terms of improving over standard care, which was 12-step based. When she had this warm handoff with existing members, she improved outcomes at 6 and 12 months, and those individuals were much more engaged. Now, all of those models I've just described, for which there is good randomized controlled evidence for, they were all outpatient settings. And as I mentioned, there's this other model, inpatient, where a lot of 12-step treatment is inpatient. There are inpatient models of care, including the quote-unquote Minnesota model. Now, we don't have any randomized studies. It's harder to do randomized studies, as you might imagine, to randomize people to different types of residential care with different models. But what we can do is look at quasi-experimental studies that are well conducted. And this is a couple that I'm going to show you here, a couple of outcomes from this very large study that was done in the Department of Veterans Affairs. And what this study did was it looked at the differences in the clinical process and outcomes of patients, all kinds of addiction patients, not just alcohol, but other drug disorders as well, and then followed them up for 5 years after they received these residential treatments. About 1/3 of the treatments were 12-step, heavily 12-step oriented. About 1/3 of these residential programs were cognitive behavioral, and about 1/3 were eclectic, both kind of a hybrid. What I'm going to show you here is the difference in 12-step and CBT, so the cognitive behavioral programs, residential programs where veterans went, or the 12-step oriented. And what we found in this study was that when we looked at risk factors for dropout from 12-step groups post-treatment from any type of program, so these could be CBT or 12-step, what we found was that the risk factors, there were a number of risk factors for dropout from 12-step groups at treatment entry, as you can see here, with a higher number associated with a higher risk for dropout. And those who dropped out of AA and NA at 1 year was about 40%, and those individuals had a 3 times higher rates, higher odds of relapse in that first year. So going to AA and NA was good. If you didn't go, you had a poorer outcome following treatment, regardless of which treatment program you came from. But what was interesting here was that if you went to a 12-step program, your odds of dropping out were much lower than if you were in a CBT program, particularly if you were at high risk of dropout. You can see here on the right-hand side. So we call this a treatment by attribute interaction, where there's a propensity for dropout. Those who dropped out did worse, but the treatment environment made a difference, made a big difference for those who are at high risk for dropout, as you can see on the right, reducing it by about half. This was another couple of studies that was done by Keith Humphreys using the same data set. Again, this is looking up at 1 year and 2 year post-residential treatment for addiction. And what they found when they compared looking at patients receiving very pure cognitive behavioral treatment versus very pure 12-step treatment, they had very similar outcomes, as you can see, except that the 12-step facilitation condition had significantly higher rates, 30 to 50% higher rates of continuous remission relative to CBT across the 2-year follow-up. And they were more likely, the 12-step patients were more likely to have engaged in 12-step indices of involvement, like getting a sponsor, having a home group, talking to a sponsor outside of meetings. And what they also found in this study was the cost effectiveness for the first time of 12-step treatment. So this is good news in the sense that not only was 12-step treatments doing as well on every single outcome metric, but better in terms of helping patients achieve sustained remission, but they also did it at a substantially reduced healthcare cost, you can see on the right. Just in these programs alone, so compared to the cognitive behavioral programs, the 12-step facilitation treatment programs produced about $15 million cost savings across these 8 programs across that 2-year period. So that's a significant saving. That's in 2018 dollars. When we look at young people, we see converging evidence as well. This is a study, the data for which was collected by Dr. Sandra Brown at UCSD, University of California, San Diego, and patients were followed up in this study over 8 years. And these were adolescents treated on average at average age 16 or 17, followed up through roughly average age 24. What we found when we looked at the trajectories of this group of adolescents, there was 160 adolescents followed up over this 8-year period following treatment. You can see here the different kinds of outcome groups. We have abstainers in remission, infrequent users, those worse with time, and frequent users. And you can see the magnitude of the difference in terms of the abstainers, much more likely to be attending AA and NA throughout the study period. When we looked at early participation, we found that roughly in the first 6 months to 1 year, if these youth were going to 2 to 3 meetings a week, they were able to achieve full sustained remission at a much higher rate across the 8-year period. What we found in terms where that arrow is, for every meeting attended, these youth gained an extra 2 days of abstinence for every meeting. So roughly 3 meetings a week was associated with complete abstinence. And early remission early attendance was associated with remission right through 6 years post-treatment. So even going for that first 6 months had a positive trajectory effect on the outcomes across 8 years in this very high-risk period of transition across young adulthood. Another group in California looked at cost effectiveness as well as effectiveness among adolescents and emerging adults of 12-step engagement, showing a similar story. So adolescents, this was from Kaiser Permanente programs in Northern California, followed up over 7 years. And what this group found was, again, a significant benefit relative to patients going to 12-step meetings across this 7-year period, but also a cost-effectiveness benefit with roughly a 5% decrease in medical costs with every additional meeting attended. We also conducted, in light of all of this research that has been funded and published, some of which I've shown you today, we conducted a systematic review. Myself, Keith Humphreys from Stanford, and Marika Ferry, who's part of the European Drugs Monitoring Agency. We conducted a systematic review through the Cochrane Library collaboration. So as many of you may know, the Cochrane system is viewed as the gold standard for scientific research in the area of medical interventions. And what we wanted to do here was to subject 12-step treatment and AA research to the same scientific standard that you would subject any other intervention to. In other words, a very high bar of scientific rigor to look to see, is there a clinical and public health utility of this particular intervention? And this is the way that is done. We included, because we were looking at the most rigorous studies to be able to really determine cause and effect, we only included either randomized controlled trials. These were clinical trials of 12-step facilitation interventions, or quasi-experimental studies that were well conducted and prospective, that followed patients up over time so we could look at the outcomes. And we also included healthcare cost offset. So some of those data I showed you earlier, those studies of cost effectiveness. So if you link patients to groups like AA, does it actually produce healthcare cost benefits by reducing emergency department visits, expensive overnight stays in the hospital, and so on? And participants that we looked at in this review, they had to be in studies where there was non-coercion, so they weren't criminal justice mandated to attend, so they were voluntary. And we included any outcome at all that was reported in these studies. Most of the studies reported these alcohol-related outcomes, as you can see here, which are standard outcomes in terms of days of abstinence, drinks per drinking day, as well as consequences, addiction severity, and as I mentioned, the economic analyses as well. I think what's, again, surprising here is that when you look at the most rigorous level of evidence in this review, these are all randomized controlled trials. They're all manualized interventions with high degrees of adherence, delivered with high degrees of adherence and competence, having videotaped supervision to make sure that they were all delivered with the utmost scientific, clinical rigor and fidelity. You can see here in blue the relative benefit of those assigned to 12-step facilitation interventions compared to other kinds of interventions. These include bona fide, well-supported interventions like cognitive behavioral therapy and motivational interviewing and motivational enhancement. So these are important evidence-based interventions to which 12-step facilitation was compared. I think even more so when you look at the relative advantage. I mentioned earlier that's 60 to 71% better outcome for the 12-step patients in Project Match relative to CBT. You see the same kind of magnitude here across the board in these studies with the highest level of scientific rigor and clinical rigor. So that's pretty compelling when you consider that this was back in the 1990s when this initial intervention was devised to link patients formally with AA, was considered to be a control condition. Turns out the control condition is proving to be a very strong treatment for sustaining remission across time. The other thing that was noteworthy when we looked at the healthcare cost effectiveness of the interventions and compared 12-step to other kinds of interventions, we found that the 12-step interventions produced a healthcare cost savings when we extrapolated it to the United States population of about $15 billion a year in reduced healthcare costs, while still producing higher rates of remission. And this is why I refer to groups like AA as the closest thing public health has to a free lunch. This is a ubiquitous, indigenous, highly flexible, long-term support infrastructure, again, a de facto part of the system of care in most middle and high-income countries. And what we have found here, and I think where the evidence is consistent and convergent, is that whatever way you look at it, whether you look at randomized controlled trials, whether you're looking at single group prospective studies, whether you look at correlational studies, they all point to the same ultimate conclusion, which is linking patients to these kinds of services, in this case, Alcoholics Anonymous, produces higher rates of remission at lower cost. The other thing I mentioned earlier is the mechanisms of behavior change. So what I've shown you so far is answering the question, does AA produce a benefit? It does 12-step treatment. If we link patients with these severe forms of these disorders to groups like AA, do they actually have as good or better outcomes? The answer to that is yes, they do have better outcomes. The question is why? How come patients referred in this fairly unsophisticated, it's not based in classical operant conditioning, there's no talk of triggers and deconditioning, cognitive restructuring. There's none of that we do in CBT or motivational enhancement type of interventions. It's fairly unsophisticated, just pure linkage and education around these things. So how come? Why is it that these interventions in particular tend to produce these better outcomes? Well, what we found in those studies and what's been found when they studied the answer to that question, how do they work, is that essentially 12-step treatments, as you might guess and anticipate, is that patients who are randomly assigned to receive a linkage to AA, the reason why they do better is because they go to AA. That's the reason. So it successfully links patients to become more engaged and involved. Now, the next question is, well, what does AA do then that produces this benefit, this relapse prevention benefit over time? So what about this part of the causal chain here, the MOBC, the mechanisms of behavior change? That's what MOBC stands for, mechanisms of behavior change. So how does AA confer that benefit? Well, from AA, of course, AA's own standpoint, it works through what it calls a spiritual awakening. And that can mean many different things to different people, including AA itself. It has an appendix that it put in the second edition, or the second later printings of the first edition of the Big Book, which really explicates and describes in more detail what this spiritual awakening is. And it describes it as a gradual change in outlook and view of oneself, as well as the worldview that comes around as a function of working through the 12-step program. So it doesn't necessarily constitute a dramatic conversion experience, as was experienced by some of the early members, but rather a gradual process of change, which is an interesting development. But nevertheless, a shift and a change in people's perspective and outlook as a function of behavioral change. So what do we know from the research? Is it a spiritual awakening? To what degree is spirituality a mechanism through which AA benefits patients and helps them to prevent relapse? We did a systematic review published in 2009 and of all the research that had been done looking at how AA works, how does AA confer these benefits? And what we found at that time was quite a few studies that have looked at more what we call common process changes. So does AA work for example, by boosting people's self-efficacy, their confidence, their coping skills, their motivation? And what we found that most of the studies actually that had been conducted up to that point in 2009 did support that notion that going to AA, it boosts your cognitive behavioral coping skills, it boosts your motivation and maintains it for recovery. And of course, it changes your social network. There wasn't much focus on spirituality at that point. But we did, and others have done, mechanism studies where we look at the way that AA works. And in fact, 3 independent studies have shown that AA helps to reduce relapse risk by boosting spirituality. And we can talk about how spirituality, maybe in the discussion, how spirituality boosts might actually result in more remission and less relapse. How does that itself kind of look at downstream at how spirituality actually can present relapse? And perhaps we can discuss that. But these 3 independent studies all found the same thing, that going to more meetings produces higher remission, and that remission is explained by boosts in spiritual practices. We've also found that going to AA meetings boosts these 12 promises, the 12 promises that are part of the AA, kind of part of really the spiritual awakening, maybe the explication of the spiritual awakening in many ways, of the changes that occur as a function of working the 12 steps and participating in meetings. But what we found here is that the way that it helps reduce relapse risk is by reducing craving. We did not find that AA reduces relapse by reducing anger, or it has not been found that AA works to improve remission and reduce relapse by reducing selfishness or self-centeredness. We did find, as I mentioned, that AA works by dramatically changing people's social networks. You can think of the social network as really the soil in which all the other recovery nutrients are exchanged and absorbed. And AA, as you can see here, with greater attendance, you can see it drops the heavy negative drinkers and drug users out of the network at the bottom here, and increases, excuse me, sorry for coughing. It increases adoption of abstainers and recovering individuals into the social network. And just the magnitude of this change is really quite striking. Another way that AA has been found to work is by reducing impulsivity. So impulsivity is leaping before you look. So AA, one of the ways that AA helps to reduce that relapse is helping the people to consider their actions, maybe talk to a sponsor or other members before they make decisions, before they act impulsively, which can be detrimental to remission and recovery. So if you look about, all of those studies that I've shown you there, they all looked at these individual factors, right? Things like motivation, coping skills, self-efficacy, social network changes, spirituality. So depression symptoms. What happens if you put them all together, right? If they're all operating through AA participation, then which one's the most important? And so this is a question we tried to address, and we were able to actually use a very large clinical sample to be able to look at this question. So in this paper, what we did in this analysis, we looked at 6 different mediators together. So the question being asked here is, what's the relative importance of these 6 different mediators in conferring this benefit attributable to AA in terms of relapse prevention? And spirituality is in green here in these circles. We also have two measures of self-efficacy or confidence in people's ability to cope with different kinds of situations, high-risk social situations, as well as feeling depressed or angry, having negative affect, anxiety. That's in the blue, if you look on the top right. That's the blue segment. That's confidence in coping with negative affect, depression, anxiety without drinking. The purple segment is confidence in people's ability to cope with high-risk social situations where alcohol may be present. The green segment is spirituality. So that does AA work by improving spirituality? Depression symptoms are also in here. So does AA work by reducing depression? And then we also had two measures of social network factors. So the question being asked and answered here is, does AA work to reduce relapse risk by boosting your social network adoption of recovering individuals into your social network? And simultaneously, does it work by reducing the negative influences, the heavy drinking social network members out of your social network? So we had these 6 different explanatory factors trying to explain the effects of Alcoholics Anonymous on relapse prevention. And what we found, as you can see here on the, let's just take the right-hand side, which is intensity of drinking or relapse risk in the year following treatment. So you can see here in the top part and the bottom part, the top part is more severely addicted individuals when they started the treatment. The bottom part, the bottom right-hand side, is less severely addicted individuals. And what we found here is different causes for different horses. In other words, the way that AA was helping people differed depending on level of severity of addiction. In the top part, we found that spirituality, in fact, was a mediator. It did explain the benefit attributable to going to meetings in terms of reducing relapse risk. Also, these other factors, as you can see here, were very important also. These other, dropping the heavy drinkers out of your network, adopting abstainers, recovering individuals, and also boosting your coping skills to cope with depression and anxiety without drinking, as well as handling high-risk social situations and managing depressive symptoms. But what was interesting when you look at the less severe outpatients is that the magnitude of these mechanisms differed, such that in the outpatients, the spirituality component was less notable. It was still there, but it didn't play as much a role for the less severe outpatient group than it did for the more severe inpatient group in the years after treatment. Where you did see a big factor was for the outpatients with these social factors, was that AA was working for those folks by boosting their social self-efficacy, their ability to cope with high-risk social situations without drinking, as well as changing their social networks, which is in the bottom right here in the orange and light blue segments. So interesting is that the same intervention here, in terms of here, it's Alcoholics Anonymous participation, is producing the same outcome benefits. These outcomes didn't differ between the more severely and less severely addicted. They benefited equally in terms of relapse prevention, but the way that AA was helping them differed. In other words, they were utilizing AA maybe differently depending on their own history, their clinical severity, and their life context. Kind of where they were in their particular life stage, as well as their life context. In addition to the particular clinical severity, history, and complexity and chronicity that they may have suffered.
Thank you, John. You're always going to be welcome back here.
Thanks, Patrick.
This is just great to have this, I mean, we all know, so many of us here, the evidence. We are the evidence. And
Yes.
so,
Yeah.
so it's just great to hear it supported, and thank you, Johanna, for doing such a great job